Hi, welcome to the second week of the Leukopak Lady series. This week we will talk about leukopaks. What are they? How are they used? How are they collected? And why is their quality so important? Today, let's focus on non-mobilized leukopaks. These are your primary starting materials for your engineered allogeneic CAR therapies like CAR-T and CAR-NK. The FDA classifies leukopaks as blood products. The FDA calls these source leukocytes and defines source leukocytes as white blood cells collected from whole blood or by apheresis and used for further manufacturing. Blood centers also call this product MNCA, although that's typically associated with patient material. A leukopak is, at its basic definition, a bag of peripheral blood mononuclear cells, so lymphocytes and monocytes primarily. They contain typically more than 90% PBMCs and as little red blood cell contamination as possible. A hematocrit of 3% or less is ideal. It's also ideal for there to be as few platelet and granulocyte contamination as possible. And we'll talk in the coming weeks about why this is so important. A full leukopak is said to contain about 10 billion PBMCs. And from my experience working with developers, this is about the minimum number of cells that they need to initiate their upstream manufacturing processes. And it's called a non-mobilized leukopak because the donor is not given any drug before the collection process. And to contrast that, a mobilized leukopak, which we'll talk about tomorrow, the donor is given a drug before collection. Leukopaks are collected through a process called automated apheresis. Blood is drawn from the donor or the patient and centrifuged through the instrument to separate the white blood cells into a layer. And that's when the instrument siphons off the PBMC layer and then returns the rest of the blood components to the donor. And this happens on a continuous loop. And to collect 10 billion cells from a donor, it could take 3 to 5 hours, although this really depends a lot on the donor's size, their white blood cell count, and their percentage of the target population and their hydration level. The makeup and the quality of the leukopak is very important to the success of the manufacturing process and is likely very important to the success of the therapy itself. And so variability in leukopak quality, it can stem from multiple factors. Contaminating RBCs, granulocytes, and platelets is a big factor. Collection times, collection approaches, and expertise can influence the quality of a leukopak. The donor cell makeup can be a factor, and then the donor characteristics themselves, like their health history and the function of their cells, can really influence the success of manufacturing. So on the next episode, we'll talk about mobilized leukopaks and compare it to these that we've talked about today in bone marrow. I'll see you later.